Hi, everyone. I'm Sandy Magana, a professor in the School of Social Work and director of the Texas Center for Disability Studies. And I'm really excited that we have a talk today about disability and disability policy. And just to let you know, I am a white woman. My background is a UT building with trees, and I have a blue shirt, length brown hair. And so I want to welcome everybody to the 2023 Dean Jack Otis Lecture. Dr. Jack Otis created the Social Problem and Social Policy Endowed Lecture Series to bring attention to current social problems and inspire university students and faculty to develop solutions to these problems. This lecture series complements the Steve Hicks School of Social Work mission, which is to provide national leadership to promote social and economic justice, alleviate critical social problems, and enhance human well-being. And we're really grateful for the generous gift from Dr. Otis that funds this lecture series, and want to recognize his family members that are not able to be here today, but who we hope will enjoy recording of the lecture. We're excited to present Dr. Lauren Bishop for this lecture, and the title is, you can see there, is the services cliff a policy cliff? Kasi will introduce Dr. Bishop a little more fully, and Dr. Bishop's work in this topic intersect really well with work that we're doing here at UT Austin, the School of Social Work, with the Texas Center for Disability Studies, as well as there's a new cultural center on campus. There's a lot going on in the disability space. Our dean is starting a new center as well. The Impact Center. I lost my place, so sorry about that. And the Center for Societal Impact. And as we participate in this lecture today and listen to current policy issues, we want to acknowledge the March 2nd, 2023 loss and the accomplishments of Judy Heumann. She's one of the great disability advocates and champions for civil rights in the US. And she was one of the founders of the independent living movement and was instrumental to the passage of the Rehabilitation Act, the Individuals with Disabilities Education Act, and the American Disability Act. So now I'm gonna turn it over to Kasi Huff, who's the chair of the Otis Lecture Committee, for further introductions.
Thank you so much, Dr. Magana. I appreciate it. My name is Kasi Huff, she, her, hers. And as Dr. Magana said, I'm the chair of the Otis Committee. I also, just to put it out there, I'm a white woman. I'm wearing a purple blouse, and I have short hair, and I am sitting in front of a Zoom screen with the UT Tower behind me. I'd like to acknowledge the members of the Otis Lecture Committee as we kind of get things started. So thank you to Dr. Diana Donito, Dr. Esther Calzada, Renee Gaitan, Thea Posel, and Stacy Jordan for all the work they did bringing this lecture to you all today. So first of all, I want to welcome Dr. Lauren Bishop. Dr. Bishop is an associate professor at the Sander Rosenbaum School of Social Work. Dr. Bishop's research uses epidemiological, advanced computational, and qualitative methods to characterize disparities in health and well-being in adults with intellectual and developmental disabilities, and as they age. Her National Institutes of Health funded program of research focuses specifically on autistic adults and how their unique mental, physical, and social needs can be properly understood over the life course to inform treatment, services, policy, and best practices. Dr. Bishop directs the Aging and Health Equity in Autism and Developmental Disabilities team at the Weissman Center, where she is a principal investigator. She is also an affiliate of the Institute for Research on Poverty, the Center for Demography of Health and Aging, and the Center for Aging Research and Education. She is a recipient of the 2022 Deborah K. Paget Early Career Achievement Award from the Society for Social Work and Research, and the recipient of a 2022 to 2024 Villas Associate Professorship from the University of Wisconsin-Madison. We are so happy to have Dr. Bishop here today to talk with us. And then we have two attendees who are going to be responding to kind of the thoughts that Dr. Bishop has, and also answering questions after Dr. Bishop finishes talking. The first one is Dr. Magana, who you just met, and a little bit more about Dr. Magana. She holds the professorship in autism and neurodevelopmental disabilities in the Steve Hicks School of Social Work. And she is the executive director of the Texas Center for Disability Studies and director of the Autism Consortium of Texas Leadership Education in Neurodevelopmental and Other Related Disabilities. And then we also have Larissa Minner, who is joining us today. Larissa is a passionate speaker and expert in disability justice, autism, and neuroinclusion. As a neurodivergent person, Larissa's personal experiences with inequity have fueled her drive to create inclusive environments that celebrate diversity. She's worked with top organizations like PayPal, the Autism Society of Texas, and Safe Austin, and leads a neurodivergent support group. Larissa is committed to reducing systemic disparities between autistic and non-autistic individuals and serves in leadership roles for disability organizations. She's also conducting an original research study to improve healthcare equity for autistic people and people with related disabilities. Welcome to all of you, and Dr. Bishop, we're so happy to have you here today to share your lecture with us.
Thank you so much for having me. To start off, I want to offer a visual description. I'm a white woman wearing a wine-colored blazer with shoulder-length brown hair, and behind me I have a chair and a bookshelf. So I will be talking to you today about the services cliff, and specifically about the topic of, is the services cliff a policy cliff? So that we can, with this lecture, understand the impact of US health policy on the health and well-being of adults with intellectual and developmental disabilities. So I will, I first want to say that throughout this presentation, I'll be using a combination of person first and identity first language. So person first would be saying a person with intellectual and developmental disabilities. When I talk specifically about adults who are diagnosed with autism spectrum disorder, I'll be using identity first language and saying autistic adults, because research has found that that terminology and using identity first language is preferred by autistic adults. So with this presentation, I'm hoping that by the end of the presentation, you'll be able to characterize the services cliff for adults with intellectual and developmental disabilities, that you'll be able to explain childhood and adulthood eligibility criteria for US health policies, and that you will understand the support needs of adults with intellectual and developmental disabilities in social work settings, and then finally envision policy solutions that can inform research and advocacy. So first, a bit of an overview on disability. So disability is thought of as an umbrella term that covers impairments or challenges, activity limitations, and participation restrictions. So we can think about an impairment as a problem in bodily function or structure, an activity limitation as something that's encountered by an individual in executing a task or action, and then a participation problem is experienced by an individual in involvement in life situations. I want to say that disability in many ways is socially constructed, so we think about disability as something that is here in part because of the way that society perceives people and disability and restrictions. But that when we think about this from a social or medical model, we can come to different conclusions. I'll be using a combination of both, which fits with the emerging field of critical disability studies. So developmental disabilities include both intellectual disabilities and autism spectrum disorder, and it refers to conditions that really originate during the very early developmental period. And developmental disabilities over time can create challenges with senses, including response to pain, cognition, mobility or ability to get around, health, as well as function and independence. Intellectual disabilities specifically affect cognitive and personal function and are typically defined as an intellectual disability, which is an intelligence quotient score below a level that is 2 standard deviations below the mean. And these interfere and affect behavior and daily living skills from birth to death. Developmental disabilities, on the other hand, are typically thought of as neurodevelopmental disabilities, including intellectual disability, but not always intellectual disability, that affect growth, development, and function over a life term. And we use these terms somewhat interchangeably, but they are distinct concepts. Throughout the presentation, I'll be talking about intellectual and developmental disabilities as a full group, but these are distinct concepts that we could talk about in more detail in the Q&A. When we think about disparities in people with intellectual and developmental disabilities, there are a lot of factors that have led to disparities and what we see today in terms of the disparities in health and well-being. So historically, people with intellectual and developmental disabilities were often institutionalized and experienced mistreatment and abuse within asylums. Currently, post-deinstitutionalization, people with intellectual and developmental disabilities often experience a fair amount of social isolation and exclusion and poor access to high-quality health services. These disparities do lead to, in some cases, heightened morbidity or more health problems over time, as well as early death. We've done some research looking at theoretical models of health disparities, specifically in autism spectrum disorder. And throughout this presentation, I'll share a little bit about my research, but mostly focus on Medicaid and Medicare policy. I think that something that we also want to think about is the fact that disparities can often be related to place. So we published a paper in 2020 that looked at place and whether there are deserts in terms of services or oases. Places where there are more or less levels of access to services. And we found that autistic people who live in rural areas had fewer available autism service providers than autistic people who lived in suburban or urban areas. And that folks who were autistic who lived in wealthier suburbs had better provider availability, while there were fewer providers that were available within poorer or urban neighborhoods, especially in the Metro Detroit area. This study was conducted in Michigan, and we're right now writing a grant to expand this across the US. But, I think it's really important to think about place as interacting with disparities in folks with intellectual and developmental disabilities. We've also done some work on early morbidity and mortality in autistic people. And morbidity refers to health problems, mortality refers to death. In some of these studies, our group and others have found a 2 to 3 decade decrease in life expectancy. And we've also found that autistic people experience higher rates of most health problems compared to people who are not autistic, and that these health problems may begin earlier in autistic people compared to non-autistic people. Because there is not in autism, like most intellectual and developmental disabilities, a known biological reason why people may experience early morbidity and mortality, we can think about this as something that is related to disparities and something that could be changed through services and through policy solutions. So I pull up this figure, which is a figure that was created by one of the doctoral students who works very closely with me, Kylie McLean. and this is a complex figure, but I bring this up to demonstrate that in some of our research on the qualitative experiences of autistic adults, as well as the quantitative research that we've done in my lab, we found that barriers to high quality healthcare and to health outcomes, to positive health outcomes, are very, very multifaceted. And they happen at the individual provider, system, and policy level. And in many cases, the individual experience of the autistic adult or the adult with intellectual and developmental disabilities interacts with the healthcare organization, the environment within the healthcare organization, the level of accessibility related to technology and tools and accessibility within the healthcare system, and the different types of tasks that are completed by healthcare providers. And that this then leads to differences in the processes by which folks receive healthcare. And then that also interferes and interacts directly with their health outcomes and leads in many cases to poor overall health status and the heightened presence of preventable health disparities like asthma, diabetes, heart disease, and hypertension. You can look at this graphic in more detail in the slides that will be provided at the end of the presentation, but I say this to really just drive home the point that the causes of health disparities in people with intellectual and developmental disabilities are exceptionally complex. They are deeply, deeply rooted in contemporary and historic inequalities that people with intellectual and developmental disabilities experience, and they involve participants at all levels. In this talk, I'm going to be focusing specifically on policy, but we could spend a lot of time talking about individual provider and system level challenges. Just to talk a little bit about this, adults with intellectual and developmental disabilities, in many cases, need some level of services and supports throughout their lives. And these services and supports can do a lot to help reduce early mortality and encourage healthy aging. So we can look at social supports, so increasing inclusion in social, recreational, and leisure activities. We can look at supports for families, and Sandy will talk about this in more detail when she talks at the end of my presentation. And family supports can include support around care transitions and parent death, as well as supports to increase caregiver well-being and family well-being. We can look at housing supports, so supports for independent living and family living, as well as support for nursing home care and for skilled nursing facility providers to better serve the needs of folks with intellectual and developmental disabilities. And healthcare providers and health can include special care to mitigate disability-specific risks and accelerated aging in terms of early screening, but also to account for preventive and routine healthcare. And then we can also do things to provide support to encourage activity in adults with IDD, like is needed for all adults. So in terms of the policy implications, there are very high, both human and monetary costs to folks with intellectual and developmental disabilities, to their families, to their communities, and then to government programs like Medicare and Medicaid. And providing care that is adequate at a minimum, not just high quality and comprehensive like we would like it to be, is as growing cohorts of folks with intellectual and developmental disabilities age into adulthood and then into older adulthood, we're going to see that this is much more complicated, intensive, and costly as the population changes and as the prevalence of intellectual and developmental disabilities, and specifically autism, increase. So let's talk a little bit about the services cliff. So in the field of intellectual and developmental disability adult services research, we talk about something called the services cliff, which essentially refers to the discontinuation of services at the point of high school exit. So during school, during elementary and high school, as well as for early intervention services, people who are diagnosed with intellectual and developmental disabilities often have access to a relatively large number of services and supports that support their overall well-being and their access to health and healthcare. However, at the point of high school exits, there is a drop off in the availability of services, and oftentimes the only services that continue to exist for individuals with intellectual and developmental disabilities after high school graduation are Medicaid, Medicare, and supplemental security income. However, Medicaid and Medicare can be really complex to understand. And I'll try to break this down in a little bit more detail in this presentation, but they can be complex for providers to understand and for policymakers to understand, and even more complex for families to understand. We also find, so in this picture, on the left side is the number of services that are needed, and on the right side is the number of services that are received. But this services cliff may actually precede high school exit. So there's a slight decline in the number of services received before high school exit, and then there's a large drop off, especially for people who have intellectual disabilities relative to people with both intellectual disability and autism, or autism alone. And then the number of services that are needed also increases after high school exit. So we're seeing this drop off in services received, as well as an increase in service needs. And this is something that is directly related to the policy system and to the fact that we lose access to a lot of services, and the qualification criteria for Medicaid changes in adulthood. So this presentation will focus specifically on Medicaid and Medicare, but I also want to note that the Affordable Care Act impacts healthcare for people with intellectual and developmental disabilities through a number of provisions that happen within the Affordable Care Act. So I think really importantly is that there is an increase in the age under which people can be covered by their parents' health plans, by their parents' private employer-sponsored health plans until age 26 for folks who are in school or receiving some type of education. There's also, through the Affordable Care Act, enhanced affordability of insurance through the marketplace and through marketplace plans, through subsidies that are applied to folks based on their income. The Affordable Care Act also reduces the impact that pre-existing conditions have on people's ability to receive access to healthcare. So insurance plans are no longer able to discriminate based on pre-existing conditions like intellectual and developmental disabilities. And the Affordable Care Act also improved access to preventive services, especially for women. And then in some states, although not Texas, which we'll talk about in a little bit of detail later, Medicaid was expanded to include people with incomes up to 138% of the federal poverty level, which increases the income limit pretty considerably for access to Medicaid. So Medicare is something that we often think about as a federal health insurance program that is for people who are age 65 and older. However, Medicaid also covers certain younger people with disabilities, which we'll talk about in more detail, as well as people with end-stage renal disease or kidney failure, or Lou Gehrig's disease or ALS. There are three different parts of Medicaid. There's Part A, which covers hospital insurance, Part B, which covers medical insurance, and then Part C, which covers prescription drug coverage for people under 65 with a disability. So how do you qualify for Medicare if you're under age 65 and you have a disability? So primarily this pathway is through having a work history where you have paid Social Security taxes for Social Security disability insurance and Medicare. And if you qualify for SSDI, you can then qualify for Medicare as part of SSDI, and they have to have received Social Security disability benefits for 24 months in order to qualify for Medicare. So this is for people who have a work history, but who have been determined by the Social Security Administration to have a long-term disability that prevents them from being able to work. Also, for folks who are diagnosed with end-stage renal disease, they qualify for Medicaid after that diagnosis or Lou Gehrig's disease. Medicare is funded through the Social Security Administration or by taxpayers through our FICA taxes, which go into trusts that pay for our retirement, which is Social Security and Medicare. So in terms of mandatory spending breakdowns, this is a figure from 2019, but it shows that the budget for the Social Security Administration is quite high in terms of mandatory spending and includes a large proportion that covers in this budget that goes towards Medicare and Medicaid. So Medicaid is the primary program that provides health insurance to folks with intellectual and developmental disabilities. And it provides free or low-cost health coverage to as many as 70 million Americans, including eligible low-income adults, children, pregnant women, elderly adults, and importantly for this presentation, people with disabilities. It's administered by states, and states have to follow certain federal guidelines for their Medicaid programs and fund these programs jointly. But the administration and the specifics of Medicaid are determined by states. Currently, it's the largest source of health insurance coverage in the United States for all Americans, but it's also the largest source of insurance coverage for people with intellectual and developmental disabilities and covers the majority of folks with intellectual and developmental disabilities in childhood and adulthood. This program is means tested, which means that your income and assets determine your eligibility for the program, and that you can qualify for a program like Medicaid to help out. It is an entitlement program, which is a federal program or provision of law that requires payments to any person or unit of government that meets eligibility criteria established by the law. So Medicaid is funded through the federal Medicaid assistance percentage. So this program, the federal government guarantees matching funds to states that qualify for Medicaid expenditures, and states are guaranteed at least $1 in federal funds for every $1 in state spending on the program. So the more a state spends on Medicaid, the more the federal government will pay. So for example, if a state has a 50% match rate for Medicaid, they may have a 65% match rate for the Children's Health Insurance Program, or CHIP. And this is intended to incentivize states to provide robust programming to children with special healthcare needs so that they receive early detection and care. And Medicaid programs, because of this, look very different from state to state. So Texas's program looks very different from Wisconsin's program, which looks very different from Pennsylvania's program. I think that something that is important to say here is that some states have a specific program that provides additional Medicaid funds for specifically autism spectrum disorder in children. Only one state, Pennsylvania, has a program that provides additional funding and additional services and supports for autism in adulthood, which is Pennsylvania. So for folks with intellectual and developmental disabilities, there are three different, we'll call them doorways to qualifying for Medicaid. So for children, a child's disability diagnosis can qualify for them for Medicaid. And for children, only the child's income is taken into account when determining whether they qualify for Medicaid based on disability. In adults, you can qualify for Medicaid based on income. States set different income criteria for qualification for Medicaid based on family size, and the states will then allow people to qualify for Medicaid based on income, regardless of whether or not they have a disability diagnosis. In many states, including Texas, adults who do not have children do not qualify for Medicaid unless they have a qualifying disability. So this mostly supports parents of young children and young children who are low income. And then there's also another pathway to qualifying for Medicaid, which is very important for folks with intellectual and developmental disabilities, and the way that most people with IDD qualify for Medicaid, which is through income and disability. So if you qualify for supplemental security income, SSI, as a disability diagnosis and disability criteria and meet the asset limits and the income limits for SSI, you also automatically qualify for Medicaid. Something to note is that proof of citizenship is required for all Medicaid programs. So Medicaid does not cover non-citizens. So why is Medicaid so important for people with disabilities? As of 2017, Medicaid, or the Children's Health Insurance Program, covered about half, so 47% of children with special healthcare needs. And these children with special healthcare needs, we can think of as children who have physical disabilities, intellectual and developmental disabilities, or serious behavioral disorders and mental illness. And Medicaid pays for a really broad range of health services, so medical services, as well as long-term care services through the home and community-based waiver system for children with disabilities. And many of these services are not covered at all through private insurance, or are only available in very limited quantities through private insurance. One example of this is early intervention for autism, which is often not covered to the degree that it is covered in Medicaid through private insurance. And then Medicaid and CHIP also make insurance coverage both affordable and available to many children with disabilities and their families. And to some degree, for children who qualify for Medicaid, they are accessing, in many cases, a uniform set of services rather than just the services that their private insurance will cover. So in adulthood, Medicaid is also exceptionally important. So for adults with intellectual and developmental disabilities, we think of Medicaid as in many cases, one of the only sources of funds that can help folks live and work in the community, and live with their friends and family in the community, and avoid more segregated care settings or restricted care settings such as nursing homes or institutions for people with intellectual and developmental disabilities, which we know based on lots of research are often very bad for the overall health and well-being of adults with intellectual and developmental disabilities. So at the national level, and at the state level, state and federal Medicaid put together provide more than 75% of the funding for services for people with intellectual and developmental disabilities. So in many cases, the social safety net for folks with IDD would just not be available if not for Medicaid. And Medicaid can also be very critical for people with intellectual and developmental disabilities who may be unemployed or underemployed, and who therefore don't have access to high quality employer-based health plans, or because they have greater medical needs that often may lead them to require some assistance with their activities of daily living and independence throughout their lifetimes. And the program covers over 10 million non-elderly people with disabilities in the United States. So it's exceptionally important and provides a really large amount of funding. So Medicaid also plays a massive role in healthcare coverage for Americans. So specifically for people with disabilities, so non-elderly adults with a disability, 45% are covered by Medicaid. And then nursing home residents, which primarily include older adults, 62% are also covered by Medicaid, given the high cost of nursing facilities. It's also something that very importantly covers many children and children below the federal poverty line specifically, and then pregnant women in addition. So Medicaid also, when people think about Medicaid, they often think about just health insurance coverage, but Medicaid also covers things beside healthcare, and specifically that is home and community-based services through the Home and Community-Based Services Waiver Program. States are given funding by the federal government to target their waivers to areas where they feel that they have the most need. And in the United States currently, there are more than 300 different home and community-based services waiver programs. Some of them are managed care organizations that are, taking care of providing these care. Some are person-centered and choice providing. And of these optional benefits and home and community-based services waivers, these programs can help people with disabilities live and thrive in their communities. And it's just one type of waiver program, and states can target these waivers to areas where they feel like there's the most need. And the programs, I think, are really important in terms of covering needed services and supports. So in Wisconsin, we have two different programs, Family Care and IRIS. Family Care is a managed care home and community-based services waiver, and IRIS is a self-directed program. And right now we're in the process of doing some research on which of these programs is more effective in reducing the risk of institutionalization and enhancing the health and well-being of adults with intellectual and developmental disabilities. Home and community-based services waivers can cover lots of different types of services that are not typically covered by Medicaid in general, but are covered by these home and community-based services waivers. So for example, they can cover respite care for the caregivers of children or adults with more complex disabilities. They can provide services that include provision of a home health aide. They can include medical supplies and equipment or home modifications that can help make homes more accessible. They can include transportation services for non-medical reasons, and they can provide transportation to and from medical appointments. So home community-based services waivers are really important, and they provide a lot of very, very needed services. Medicaid also changes a lot in terms of what it covers throughout the adult lifespan and the full lifespan. So the Policy Impact Project out of Drexel University that's run by Dr. Lindsay Shea's lab put out this really nice overview of Medicaid services for autistic people in the last couple of weeks. And in this graphic, you'll see that in early childhood, so between 0 and 2, Medicaid covers early intervention services. It also covers prenatal care services and screenings for autistic mothers. So for childhood, it can cover diagnostic and evaluation services as well as intervention services, and then continued screenings, diagnosis, and treatment services for intellectual and developmental disabilities. During the transition to adulthood, during this period where the services cliff is happening, Medicaid covers healthcare transition services that can shift folks from pediatric care to adult healthcare, and supports for transitioning into adult developmental disability services and care. In adulthood, Medicaid will cover services to support community living, things like life skills, in-home care, self-care, and supported employment through home and community-based services waivers. And then it will also cover adult inpatient and outpatient physical and mental health services, plus some behavioral health care. And then in later adulthood, after age 65, Medicaid can help to cover long-term services and supports for aging autistic adults and other aging adults with intellectual and developmental disabilities. I think something really important to point out here is that Medicaid doesn't typically cover adult diagnostic services. So if an individual suspects, for instance, that they have an autism diagnosis, Medicaid would be unlikely to cover that for an adult, but would cover that for children. So I've gone through some of the real basics of Medicaid and Medicare policy. But I want to talk about how we can reimagine the policy landscape to reduce these pretty stark disparities in adults with intellectual and developmental disabilities. So I'll talk a little bit here about this and then go into some more detail, specifically about the Medicaid expansion, about, expanded access to ABLE counts, and about block granting Medicaid. We can do things to revamp the existing services and supports that folks with IDD have. So one thing that can be done. So the asset limit for SSI and SSDI is currently set at $2,000, which means that if you have savings in excess of $2,000, you would not qualify for SSI or SSDI, which would then make it so that you didn't qualify for Medicare for SSDI and Medicaid for SSI. Increasing this asset limit is really important and something that hasn't been done for many years and has not responded to inflation. ABLE accounts can help with that a little bit, but there are some restrictions on ABLE accounts that make this inaccessible for a lot of folks. We can also do things to ensure the equitable geographic distribution of access to providers. So we know based on our research and the research that others have done, that folks who live in service deserts often lack access to healthcare providers, and specifically healthcare providers that take Medicare and Medicaid. This is a particularly big challenge in rural counties, and in particular rural counties where there are a lot of Medicaid beneficiaries. It can create long wait lists for care in addition to long wait lists for access to services. We can also do things to educate providers about intellectual and developmental disabilities and the care needs of people with intellectual and developmental disabilities so that they can best serve their needs. From a policy perspective, I think something that is really important to include here and think about is the idea of nothing without us, or nothing about us without us. And, really including adults with intellectual and developmental disabilities in all policy making and implementation planning for policies. We can also do things to expand access to an uptake of ABLE accounts, which can help to deal with the SSI and SSDI asset limits. We can do things to increase reimbursement rates for providers and direct care workers. Currently, the reimbursement rates are exceptionally low. And because of these low reimbursement rates, we have a real issue with maintaining particularly direct care workers. Texas, the rates are very, very low. I think $7 for direct care workers per hour for reimbursement rates. And then for medical providers who are providing services to folks who have Medicaid and Medicare. We can also increase the funding specifically to include longer appointments and wraparound care for medical providers so that they can spend more time with their patients with intellectual and developmental disabilities. And then we can provide funding for things like health navigator programs that can help people better access healthcare and better manage their own healthcare. And then I think really importantly, maintaining the current Medicaid funding structure and not block granting Medicaid and therefore reducing funding. So the Medicaid expansion, I touched on this briefly before, but the Affordable Care Act expanded Medicaid to coverage to most adults, not just adults with children, with incomes up to 138% of the federal poverty level, which would be $20,000 about for a single individual in 2023. So with this expansion of Medicaid, states are provided with a 90% enhanced federal matching rate for their expansion populations. So they're given additional money when they spend more money on Medicaid. And the Kaiser Family Foundation found in a comprehensive review that the Medicaid expansion can help expand coverage and reduce the number of people who are uninsured. It can improve access to and utilization of healthcare. It can reduce uncompensated care costs to providers, and it can improve care affordability for care recipients. And then finally, and I think very importantly to us as social workers, it can reduce racial and ethnic disparities in care coverage. So in this map, you'll see, so in blue, in the dark blue, we have states that have adopted and implemented the Medicaid expansion. And then in the lighter blue color, we have states, which include South Dakota and North Carolina, that have not have adopted but not implemented the Medicaid expansion. And then in orange, it shows states that have not adopted the Medicaid expansion. And the states that have not adopted the Medicaid expansion are Wisconsin, Wyoming, Kansas, Texas, Tennessee, South Carolina, Georgia, Alabama, Mississippi, and Florida. which means that states, so in the state of Texas, you know, a single adult with 2 children would make less than $4,000 a year to be able to get Medicaid coverage, which is a very low income and leaves a lot of people who are the working poor out of coverage for Medicaid. This affects folks with intellectual and developmental disabilities who don't qualify for Medicaid because of their disability, because many adults with intellectual and developmental disabilities who don't have SSI or SSDI are underinsured or uninsured and underemployed or unemployed. So another really important thing in the health policy landscape that's important to talk about is ABLE accounts. So these accounts are Achieving a Better Life Experience accounts, and the Achieving Better Life Experience Act authorized these tax advantage savings accounts for people with disabilities and their families. Folks who qualify need to have a disability that started during childhood or adolescence. And what these accounts do is they allow families to save up to $100,000 in an account that protects the eligibility for Medicaid, SSI, and other federal anti-poverty program benefits. And these funds can then be used for a number of different purposes that are related to care and independence needs for folks with disabilities, including housing, healthcare, independence, or quality of life. You know, if we were to allow for additional funds to be saved in ABLE accounts, this could increase quality of life for folks and increase their social safety net individually. And there's also a need to increase uptake of these accounts and encourage families to start an ABLE account for their children, even if they can contribute only small amounts of money, because this money will then be saved and help adults with intellectual and developmental disabilities maintain their healthcare coverage. Another really important thing to note is that block granting is a proposal that has been coming up very often recently, which would set the total amount of federal reimbursement, and states would be responsible for covering the cost beyond their federal allotments. And under a block grant, if a program cost exceeds the federal spending cap due to a variety of reasons, such as increased enrollment, or something like the COVID-19 pandemic, states would then have to spend more or reduce the services that they provide. So what this does is it has the possibility of forcing states to reduce eligibility or limit their services and supports to children and adults with disabilities in order to save money. So under a per capita cap, the federal government would set a limit on state reimbursement per enrollee. So people with disabilities who are eligible for Medicaid or CHIP would have higher per enrollee spending than other children and adults who are on Medicaid. And therefore, the per capita cap would limit spending per enrollee and would disproportionately disadvantage people with disabilities, specifically people with intellectual and developmental disabilities, who need access to necessary and often very expensive services that are often unavailable through private insurance. And block grants or per capita caps would create institutional bias within Medicaid that would limit the health services and supports that would be available to adults and children with intellectual and developmental disabilities. Keeping Medicaid as an entitlement program with flexible federal funding based on state spending would reduce the chance of this happening. You know, so if your state wants to add more enrollees, per capita caps would allow that to happen, and the current structure would, but block grants would not. And then if we wanted to, in states, add more services or cover new prescriptions or increase provider reimbursement, the current structure of Medicaid allows for that, but neither block grants nor per capita caps are able to do that. So I've given you all a really brief overview of Medicaid and Medicare specific to intellectual and developmental disabilities. And I now want to turn the discussion over to our group. I think Larissa Minner is going to share information first about her experience and lived experience related to this presentation.
Thank you, Lauren. Okay, so I'm a white woman wearing a purple shirt, and I have brown and purple hair. I identify as autistic, as well as I'm diagnosed. So I can speak from personal experience that I was on Medicaid. It's been years, but I was on Medicaid. And honestly, when I lost my benefits, when I got married. And I honestly could not tell the difference because it was that hard for me to find doctors that accepted Medicaid because the reimbursement that they get is so low that I think only one of my doctors covered it. And I don't believe my medicines were covered. There may have been one, but the coverage was it was so poor in my experience that I really could not tell the difference. It was very hard for me to find doctors, especially specialists, with the accepted Medicaid. There was someone that asked something about that in the chat, and I just wanted to say that my understanding is a good part of why it's hard to find healthcare providers that accept Medicaid is the lack of coverage or lack of reimbursement from insurance. My understanding is that they might lose money. So that's definitely something to keep in mind with policy, I would think, in the future. I'll look at some of the other questions later, but yeah, I just wanted to bring that up. I also wanted to point out, first, I think it's awesome that, Lauren, you pointed out, keep making sure that we're being inclusive to people with disabilities, especially adults with intellectual disabilities and autistic adults and those with other developmental disabilities. I did want to briefly say that I have recently learned when I thought I was being inclusive that I was not. So I'm taking the time to do research, talk to people. I was trying to get a project together recently, and I wanted to get different adults, including people that are non-speaking, those with intellectual disabilities, and other considerations. And I found out that offering an audio and video option, having a parent help out was not enough. So to be truly inclusive, I looked into it. I need to consider photo image options where they can actually take pictures to share their experiences. I need to consider allowing them to draw or have other means of communicating. I also need to include some yes and no questions. And there's just other different things I need to do, and I need to use plain language. So I did want to point out that plain language is a really great way to make things accessible. There's lots of guides. I feel like it would be very helpful. Or I consider plain language best practice, and it helps people with other circumstances too, including those where English might be their second language. And it just makes information easier to digest. So I wanted to point that out. I also wanted to quickly talk about something else Lauren had brought up. So I know you brought up the costs or how there's a limit on how much money you can have for some of these services. I did want to point out, because there is a proposed bill on the Marriage with Equality Act. And my understanding is that this can disproportionately affect those with developmental disabilities, because to be an adult with a disability on some of this, they look into when you got diagnosed or when your symptoms started. I did want to point out, because I feel like with intellectual disabilities and developmental disabilities, we have a tendency to forget that we may want to get married and that some of us can get married. And I just wanted to put that out there because I think it's important to consider that. Along those lines, I did want to briefly talk about that I think it's important to continue to make inclusive health programs, and I know there's a lot of great programs out there that are starting to be aware, but not like even with my own experiences, I can say that when I was younger, my communication skills at the time, the health and even just the sexual education, other stuff like that, which I think is important and ties into health, it was not accessible for me when I was younger. And I have what I consider privilege going on, and I have other things. And I just wanted to point that out because I have been hearing stories from adults with intellectual disabilities who are getting, who have become pregnant and they're not having services. So I just wanted to point that out. And I also wanted to say it goes without it. Obviously, I can't speak for people that have intellectual disabilities, but I did want to pass it on because I've been finding out that it's a problem. And I've also been finding out that apparently there's a problem with getting services for addiction, which is something that may have been overlooked in that population. So I feel like those were considerations. I did want to go back to the health part again. So there's a lot to cover because Lauren, you covered a lot. I did want to talk about briefly that I think educating professionals is important. And when I say that, I think it should be in the college curriculum. And really quick, because I've had tons of experiences. If I named them all, it would be overwhelming. I once had an experience with a rheumatologist and who was dismissive of my concerns. And I believe my autism was a reason for that. And she ignored a previous recommendation for MRI to rule out autoimmune arthritis. It was very dismissive. This is one of many. Later, I received an ultimately delayed diagnosis, and this is something that can cause permanent damage that can be irreversible. So we did eventually get me diagnosed, and I'm going to be starting treatment soon. But I just want to point out that it's important because I feel like social workers could help educate healthcare providers. I know it's hard to get doctors to listen, but I believe it's important for healthcare providers to listen to their patients, including those with IDD, and to provide appropriate care regardless of their background or medical history. And I did want to point out, going back to what I said earlier, intentional inclusion is something that it's very important, and Lauren, you tapped into that, but it's essential to make it like a priority. And that's what that's what I'm realizing I could have done better, and it's going to take time, but going forward with my advocacy work, I'm going to try to do better, to do intentional inclusion. And I did want to say that if you're in general, and I realize this too, it's something that should be looked at in the beginning before a program is in development. It should be in the pre-planning and planning stages. Again, I'm guilty of not always thinking that far ahead. But I did want to put that out there because I feel like often accessibility is an afterthought. And I think as we get used to keeping that in mind at the very beginning, it'll help create a more inclusive environment. And I also believe, as we're talking about policy changes, that it's essential to include those with different voices, as well as I also would say parents as well and caregivers. I think that may have been most of my comments. Real quick, I did want to put this out there that I do think it's important to make sure that we're having inclusive research, because often needs assessments will help us know what direction to go in. So again, there's lots of guides. I found guides online myself when I was creating my research project. That's why I decided to do text and audio options and pictures and other options in plain language. And I again am learning I can do this better in the future, but I did want to put that out there that we also need to do research to find out as well where to go in the direction. And I also feel like it's important to educate on transition plans, because going back to that cliff, when Lauren, when you said there's a service cliff, I was actually thinking that was a gentle way of putting it, because it was basically non-existent after I turned 18. I didn't have my diagnosis back then, but I did have an individualized education plan, but I didn't receive any support. I was basically on my own, or it felt like I was on my own for a lot of it. I still had some parent support, but I didn't understand the rules. So I did want to point out that we need to make sure that this information, again, is accessible. And it looks like that was my cue for time. I'll pass it on to Sandy.
Great. Thank you so much, Lauren and Larissa. It's really a rich discussion, and so many policies that really relate to people with intellectual and developmental disabilities. And it's good to get the landscape of it, but also just thinking about how it plays out for adults differently than children. Just a couple of, I don't have a lot of comments, but I do want to talk a little bit about the family perspective. And so, you know, we know that families are the ones that are involved as children, but even the majority of people with intellectual developmental disabilities do live at home with their families, even as adults. And that's even a higher rate, I would say, for racial ethnic minority families. They're more likely to have their children to live at home. And so, because part of it is, so some of it may be cultural, but some of it may be that there are just so few options, right? And, you know, I know somebody in the comment mentioned the Medicaid waiver program, and that's a good example of where families can get services, right? And Lauren also mentioned Medicaid waiver program. So in Texas, I think the last estimate I heard is that it's about 15 years wait list, if you can imagine, you know. So definitely, and families don't know that they, you know, as soon as their child in an early childhood is when they need to get their child on that waiting list, right? Because then, like, if your child's 3, then they're going to be 18 by the time their name comes up, possibly. And the list keeps getting longer as you go, so it could be longer even if you get your child on that list at 3 right now. So that's one challenging issue, because there are a lot of services that would help the family, like the respite services and other programs that part of that waiver program. Also direct care workers or people who can come in and provide nursing. You know, I know there were some comments about how the nursing services are being cut even in the Medicaid waiver program. So that's a huge challenge. Another big issue right now in Texas and throughout the country, but even more acute in Texas, is that the reimbursement rate for direct care workers, the baseline is $8.11 an hour. And so, you know, just being able to find a care worker, even if you have the Medicaid waiver program and you're able to, you know, pay for somebody, and that's all the money that you're able to pay. So, you know, you can walk down the street and see any fast food sign that says $16 an hour, $15 an hour. So, you know, people are going to choose those jobs over direct care work. So it's not valued at all. And you know, I hear people in other states talk about how terrible it is that it's only $15 an hour. And I'm like, yeah, what about Texas? It's $8 an hour. But so that's another challenge with being able to get those services. I know people have talked about also the reimbursement rate for Medicaid. And, you know, being you talked about this, Larissa, as a reason for why doctors and professionals don't accept Medicaid. And I think that's one of the main issues is that it's a lot of work getting reimbursed, and then it's also a very low reimbursement rate, so it makes it challenging. So unless those doctors are really dedicated to serve low resource families and people with disabilities, it's pretty challenging to find those reimbursement rates. And I think that Lauren is right that we need more education of providers, medical and all kinds of providers. And one of the things that we're doing in Texas, and I know you guys are doing this in Wisconsin, is we have a LEND program. It's called Leadership Education in Neurodevelopmental and Other Related Disabilities. And Larissa is one of our full-time trainees this year. And the purpose of the LEND program is to educate the workforce about working with people with intellectual and developmental disabilities. And so just being able to include many different disciplines, we're really, we usually have about 7 or 8 different disciplines represented, but also self-advocates and family members are part of that LEND program. So I think that's an important aspect. I think that's all I'm going to say, because I know that we want to leave time to the Q&A.
Hi, everyone. Lovedie Grossman back again. I realized I did not follow the protocol, and I apologize of introducing myself. I am a white woman with really gray hair, thank you, COVID, wearing a scarf and a gray sweater. I am here to present the questions for the panel to discuss. I am going to read one, so I might turn a bit from Q&A to make sure that I collect everything or reflect everything. But for the panel, here is the question. I have an MSW colleague in San Antonio with a 10-year-old autistic son. Even though studies show that it is cost effective for Texas to have expanded Medicaid, politicians in our state would rather not go with this option based on particular principles for those in desperate need. This individual, like other parents, was urged to apply ASAP for one of the Medicaid waiver programs that you mentioned, CLASS, Community Living Assistance Support, for her son, as there is a long waiting list. In 2022, after being on the list for 3.5 years, her son is number 61,572 on the waiting list, and Texas funded only 381 slots. Another parent with an autistic child notes that her son, who has been on the list since birth, would be 219 years old when he gets to the top of the list if this rate continues. What do all of you suggest that we do in Texas from a policy perspective to create needed changes? And I'll let anybody jump in on that.
Yeah, so I'll jump in and say here. So I think one really important step that can be taken, that is happening in a lot of states actually, is that the Medicaid wait lists for the HCBS waiver are being eliminated. In practice, it doesn't mean that folks are getting off of the wait list instantaneously. It still takes a little bit of time. But in Wisconsin, at least, I know that we eliminated our Medicaid HCBS waiver wait list, and folks are getting needed services relatively quickly, which is doing a lot to help families who are in need of these highly needed and highly valuable services. So states don't have to accept the Medicaid waiver, the expansion of the Medicaid or the Medicaid expansion to be able to eliminate the Medicaid waiver wait lists. So even if the state of Texas doesn't want to accept the Medicaid expansion, they could eliminate the HCBS wait lists, specifically for children or for adults with disabilities. But that's an advocacy thing, right? That's something that state politicians and that advocates and, hopefully advocates who have benefited from Medicaid HCBS waivers, who have been on wait lists for a very long time, would be able to push for and to push for social change. I think one thing that I'll say is that disability tends to be a relatively bipartisan area for policy and advocacy. So, right now we have a lot of partisanship in politics, but this might be a particularly good time to push for some disability policy changes that could benefit folks, and I think is really ripe for advocacy.
So I want to have a conversation with Lauren about this actually. So how they can eliminate the wait list? What is the cost of that? How would they just eliminate the wait list? Because that means they would take there'd be a lot of extra cost, right?
Yeah, so I haven't looked at the simulations for how much additional this would cost. But, right now they would receive federal matching dollars for the money that they've spent on these costs for increased Medicaid costs based on waitlist elimination. But yeah, it would be costly, and it would require an investment from the state government to be able to make those changes happen. But I would argue that, eliminating Medicaid wait lists can do things like increase parents' ability to work, which then brings in additional revenue to the state. And I don't know who has done it for Texas, but I know that there have been many health economists who have done simulations about the, actual cost to the state of eliminating these wait lists. But it is an additional cost. And it is something that states and state politicians would have to commit to from a cost perspective.
No, great things to think about for sure. I know there are a lot of advocates really advocating for the increase in direct care worker pay right now at the legislature and other kinds of things. And there's a lot of resistance to that, even though it's a bipartisan issue. So, but yeah, advocacy is really an important thing. In fact, our LEND program is going to be going to the Capitol in April and advocating across a number of bills related to intellectual and developmental disabilities. Not advocating, we can't say that because we're a federally funded program, but educating legislators about issues, right? And so we'll be spending a day at the Capitol next month.
Yeah, and one other thing I want to say is that so managed care organizations, of which there are several national, very well-funded managed care organizations that have well-funded lobbying groups, they have the ability also to advocate at the state level for increased funding of Medicaid HCBS programs. And it could be an area where folks who are advocates with intellectual and developmental disabilities or their family members could partner with these privately funded managed care organizations to do advocacy work.
Good point.
Larissa, do you have anything that you want to add?
I've been typing answers.
I saw there was one question that you answered that we wanted to make sure everybody heard. Well, there were a lot of questions. We're going to try and cram as many as possible. But with regards to that last question, Larissa, what are your thoughts?
Oh, the question that just got answered out loud or the last one that I answered in the chat?
Either one. I'm going to read the one about data. So if you want, we can move on to that question because I know Larissa's already provided some input.
Mm-hmm.
So let me move with that. The data in the presentation shows a steep drop off in service accessibility upon exiting high school. For those like myself that work in education as a school social worker, what can I do to prepare graduating and exiting students and their families?
Oh, okay. I can, I answered that a little bit, but I can explain more. So developing self-advocacy skills. I said middle school, but honestly, that should be started in elementary or as soon as you can, self-advocacy skills. And I would also include advocacy skills for parents if possible, so they can educate more effectively and keep cultural considerations. I have talked to people of different ethnicities who they have had challenges when they're assertive. Obviously we would want to fix discrimination, but also working on helping with advocacy skills and how society is more accepting. It's apparently a huge issue that I want to point out because I know I'm speaking from a a point of privilege in that area. So self-advocacy and advocacy skills, and also making sure this information is accessible. A lot of this is on the internet. I do know there's some programs helping with internet access, but there's limitations, but making sure that the information is accessible and ideally in their native language. So if that's Spanish, making sure that it's available in Spanish would be helpful. And also just related to that, I would also say it could help, depending on the student, to offer some role play or getting them familiar with some of these things, because you could do a mock, maybe not a whole application to some of these services, because some of those are hours, but you can get them prepared. And I feel like that would have been helpful when I was younger. I was at a different skill level at the time, and I feel like practicing it, and also again making sure that people know of their rights, including parents and the students.
Mm-hmm. And I can build on that a little bit, because all of the things that Larissa just mentioned can be in the context of a transition plan and should be. So there are laws around transition services that the schools are required to provide. And I believe it's in Texas, it's from age 14. So so that plan every year it should get updated and should address some of those self-advocacy skills, as well as what are the real concrete services and programs that these students should be accessing when they graduate, and getting them connected. For example, employment is a huge issue, right? And so being able to be connected to the Texas Workforce Commission, which is our Department of Rehabilitation. There are a lot of programs and services that are out there throughout the state of Texas that they can connect and pay and actually pay for and fund for people who transition. So what I do see with families, though, a lot of times they don't really know what transition is or what those services are supposed to look like. And the schools do the basic minimum in some cases and don't really educate parents. So like Larissa said, parents knowing how to advocate as well, or knowing, what their rights are, what their students' rights are related to transition. So we actually have a program called Bridge that we educate social work students, speech and language students, and special ed students on transition. And it's entirely focused. It's a year-long program. There's a really generous stipend for that. So if you're a social work student, we're looking for applications for that right now.
Yeah, and I also just want to add, getting on the HCBS waitlist is something that school social workers can help parents do for their children as early as possible. And also getting ABLE accounts set up if that's something that the family is interested in.
Well, this was almost like a beautiful segue into the next question that I have, which is, how do you think that adults with intellectual disabilities and their family members should be included in policy making and advocacy? And how can we ensure that that happens?
I could probably start off with that, because there is an organization called the Texas Council on Developmental Disabilities. It's actually federally funded. Every state has one of these, and they do an amazing job involving people with developmental disabilities in advocacy and educating about policy, legislation, and all of that. So they have there's a council that they have. I'm actually a member of the council, but there are quite a number of people with intellectual developmental disabilities on that council. And so they break down all the legislation in plain language and really, explain it at every one of these meetings, all the policies. And they also they have a great website that puts out, updates on these policies. They have a newsletter that people can get up to date. So that's a really good mechanism for people to get involved in policy.
I also want to point out, I think it's inclusivehealth.specialolympics.org. It's not policy per se, but I feel like some of the examples can be applicable for different situations. I know I named some ways earlier. There's also a ton of online free toolkits on how to include adults with intellectual disabilities in their families. So I wanted to put that out there.
Mhm.
Yeah.
And ID toolkit, I think it's .vkcsites.org has several different toolkits too. What were you saying?
Sorry, I didn't mean to interrupt. I wanted to quickly say, so there's a podcast that I really like called Tuesdays with Liz, which is produced by the Association of University Centers on Disability. And the host of the podcast, Liz Weintraub, is a really well-known disability advocate who does a fantastic job of breaking down a lot of the disability policy issues for self-advocates in particular. And, I think that if, you are an adult with an intellectual or developmental disability, or you have a loved one who is an adult with an intellectual or developmental disability, this podcast, Tuesdays with Liz, can do a really nice job of cueing you in on some of the big policy issues and giving you some tips for beginning to advocate beyond what was shared by both Sandy and Larissa.
Yeah, that's a great one. You can find that at aucd.org, and they sometimes have recordings of those.
That is some great advice, you all, and good resources to kind of point people towards. We have time for just one more question, and then we're going to kind of wrap things up. And I think that this is a good wrap-up question, although it's a hard one. If you could make one change to policy to better support the needs of adults with intellectual and developmental disabilities, what would it be, and what would the impact be?
Who wants to go first? One change.
I can take the first one. I think that what I would like to see is I would like to see increased reimbursement rates for both Medicaid, Medicare, and private insurance for healthcare providers for their appointments with adults and children with intellectual and developmental disabilities, so that the providers were incentivized to spend more time with folks and were incentivized to take patients who have intellectual and developmental disabilities into their practices. Dr. Magana or Larissa, I know this is a hard one, right?
Yeah. Reimbursement rates for Medicaid is super, super important, I think would go a long way, because we're seeing that too with the autism evidence-based services that just got authorized a couple years ago, but very few providers want to take advantage of it because of the low reimbursement rate. So it would go a long way with a lot of different programs and services. And then I would just definitely, I think we need to value caregivers. There's a lot of things that we're going through the being proposed at the federal level to reimburse and pay caregivers at an adequate level, for caregivers of people with disabilities and aging, older adults. I just think we need to really rethink how we undervalue them and pay them what they're worth. It will save billions of dollars, because people get hospitalized because they don't have the caregivers. And it's just silly.
There's so many. It's hard to pick one. I would say I feel like expanding community-based services, anything that would allow adults with IDD to be independent or as independent as possible. I feel like it's important to expand on those areas. I mentioned it a little bit earlier, but I feel like we could still use improvement in programs that make health information accessible. And that would be to both adults of IDD and their families and also providers, because adults of IDD, and I can say as an autistic person, I do know I don't get the recommended FDA screening for my doctors, and it's a huge issue. So I feel like that can make a difference. And then also more internet and computer coverage, because that can be a massive barrier for people.
Thank you all so much for these concluding thoughts. And Dr. Bishop and Dr. Magana and Larissa, thank you so much for sharing with us today, and all of our attendees. Thank you for being with us today. Thank you for your questions and participation. And this concludes the Otis lecture for this year.